Thank you very much. I hope you can hear me.
Connolly?
That was a great session. Can you hear me, Dr. Naji?
Yes, we can
Okay,
hear you,
I
sir.
think you can
Yes,
hear me. We'll get going.
yes.
Fantastic. So you introduced the concept of lipoprotein A and all of the other risk factors. And hopefully in the next 15 to 20 minutes, I can give you all a précis of why I think lipoprotein A is important and is going to become more important once we specifically have inhibitors of it, as you intimated in your truly excellent lecture. Now, if we look at lipoprotein A, and we think about why it's important, it is important because it contributes to this. This is the cholesterol exposure hypothesis. You've seen this already today. The longer you're exposed to apolipoprotein B containing proteins, the more likely you are to have atheroma. The higher the level, the quicker it will happen. And we've known this for many years. And we've concentrated a lot in our clinical trials on LDL cholesterol, but all of the apolipoprotein B containing proteins can cause atheroma. But importantly, lipoprotein A is very small. It is 6 times more atherogenic than LDL cholesterol. And we're realizing how important it is. And today I've been doing my secondary prevention clinic, and virtually everybody who's had an infarct, particularly those with a family history, their lipoprotein A is very raised, which therefore gives us a target for future therapies. Now, lipoprotein A is genetic. It is largely comes down through your family. So if your father and your mother have high lipoprotein A levels, you'll have it as well. Unlike many of the things you've just been hearing about, lifestyle modifications such as diet don't change your lipoprotein A levels. And the other thing is it varies enormously through populations, up to a thousand-fold, which is quite remarkable. We know that the molecule has two components. There is a bit like a planet, which is very like LDL cholesterol, and then there's a long tail, and that tail varies. And the longer your tail, the lower your level of lipoprotein A. And people with very high lipoprotein A's have very short tails, particularly in this area here. As you can see, Kringle too. Kringle, by the way, is a Danish pastry, as you can see. But if you have a very short tail, then you have a very high level of lipoprotein A. Now, it's an interesting molecule. Only higher primates and the hedgehog have it. It's related to plasminogen. And if you look at what it causes, it's pro-inflammatory, it's pro-atherogenic, and it's pro-thrombotic. So it might have a survival benefit in protecting us if we bleed, but certainly in the modern world, it causes atherosclerotic cardiovascular disease events. And it is around the world. Now, the percentage varies around the world. It is particularly high in sub-Saharan Africa, but you can see all around the world lipoprotein A levels are raised. And we think that it's responsible for somewhere between 1 in 5 and 1 in 20 of all cardiovascular events. Now, in the UK Biobank, this special store of 500,000 people's genetics, we've looked at it, and you can see that the higher your lipoprotein A, the more likely you are to have a cardiovascular event. And we've done that with the Mendelian randomizations, looking at the genomes. That came from the genome-wide association, looking at the genes. And if you have two bad genes, high levels of lipoprotein A, you're more likely to have cardiovascular events. And then we've measured all around the world the lipoprotein A levels, and we've seen that a higher lipoprotein A level gives you a higher risk of cardiovascular events. And it doesn't matter what your ethnicity is. This is a paper from Sam Simikas showing whatever your ethnicity is, the higher your lipoprotein A, the more likely you are to have a cardiovascular event. Now, it's interesting. I've told you that it's there throughout your life. It stays stable. You can't really change it. So very recently, Paul Ridker's looked at a 30-year study in the New England Journal looking at LDL cholesterol, lipoprotein A, and blood pressure, and also HSCRP. And if you look at LDL and lipoprotein A, they have roughly the same amount of risk over 30 years in this study of women. So it is clearly very important, but it's new. And we've heard about the history of LDL, but look at lipoprotein A. The gene was only discovered in 1963 and cloned in 87. And only very recently have we had the idea of screening patients for it. And also, if you look at publications, when I was doing my PhD in Cambridge, as you've heard, it suddenly became very interesting and there were publications. And then because we had no therapies for it, it died off a bit. But I can tell you it's about to explode because the therapies are coming and we're all very hopeful they will work. Now, how do you measure lipoprotein A? There are several assays. The bottom line is most people these days are measuring in nanomoles per liter, but make sure that you're using a good assay. And, everybody should have this checked at least once in their life. Now, if you look at what happens during your lifetime, and this is data from Denmark, ostensibly men, it's pretty constant through your adult life. Women, it jumps up a bit with the menopause, exactly the same as LDL cholesterol does, but you can see that it's static through your life. And as I've said, wherever you are in the world, whatever ethnicity, and you can see an Arabic heritage there as well, the higher your lipoprotein A, the more likely you are to have a cardiovascular event. And these are the medians for the different ethnicities. So why do we know that it is important? Well, if we look at the genetics and we look at the Mendelian randomization, we look at the genes that change your cholesterol levels and the genes that change particularly your LDL cholesterol levels, we can see that what the gene studies suggest bears out fruit in the top graphic. It bears it out for remnant or intermediate density lipoprotein. But look at lipoprotein A. Again, the genetic determinant of it, because it's raised throughout your life, you can't really change it, is quite clear. And I think it's really important when we look at it, when we think about what it's causing. You can see that it increases your all-cause mortality, your risk of stroke, your risk of heart failure. Intriguingly, it's responsible, we think, for about 40% of all the aortic stenosis. But of course, that is translating into cardiovascular events. And that's why when I see someone in clinic, one of the first questions I ask is, do you have a family history of cardiovascular disease? And if they say yes, it is usual that the lipoprotein A is raised. Now, one of the questions is, when we treat LDL cholesterol, are we treating lipoprotein A? You've heard about PCSK9 inhibitors today. They do lower your Lp(a) by 15 to 25%. But very recently, you can see Sam Simikas went back and looked at all the big trials. 4S is exactly 30 years ago this week. I was in the audience in Dallas. And if you look at statins, and I'm sure it's the same for bempedoic acid, they reduce your LDL. They're really useful therapies, but they don't change your lipoprotein A. The risk is independent. And as I've said, lipoprotein A is related to aortic stenosis. The higher your lipoprotein A level, the more likely you are to get progression of aortic stenosis. So you can see the potential here that if we found a successful inhibitor, that it might be very advantageous for prognosis. This is something we're not treating at the moment. This is something that we think is a definitive risk. So what is the distribution? You can see here, most people have a relatively normal lipoprotein A. It's only about 1 in 5 people that have a raised lipoprotein A. And key thing is, per molecule, it's much, much more atherogenic than LDL or the other ApoB containing particles. Very, very atherogenic. And it's probably because it's small and it gets into blood vessels. And therefore, for us, for the last decade here in Birmingham in the UK, we've measured everybody's lipoprotein A. And that's partly because we suspect in the future there'll be specific inhibitors, but it also allows us to look at the family and see whether they're also at risk and perhaps get the other risk factors such as LDL cholesterol, hypertension, diabetes under control. See, we're now doing a degree of family screening, but that is very much becoming the normal now in the guidance. We've got all the major guidance there. You can see that a family history of events is a reason for screening, premature events are a reason for screening, but everybody, I think, should have their lipoprotein A checked at least once in their lifetime so we can see where it is and know their risks. And of course, that is leading us to therapies. Now, we don't have therapies yet, but we're very, very near. We've got pelacarsen, which is a monthly treatment, which lowers your lipoprotein A by 80%. My friend Steve Nichols in Melbourne has an oral inhibitor that lowers it by 65%. And there is a small interfering RNA coming probably in the next 3 to 4 years, a bit like inclisiran, but this time for lipoprotein A that may be, if anything, even more effective. Now, if we look at pelacarsen, you can see that it inhibits lipoprotein A by 80% at the top dose. That dose we've been trialing in the Horizon trial. I'd expect that we'll get top-line results early in the new year, and certainly by the end of March, I would anticipate at a major American conference this is likely to be presented. So watch this space. But if this works, this is going to give us a whole new risk reduction therapy that potentially we can treat patients with. So 20 minutes quickly on lipoprotein A. It's very frequent. 1 in 5 of us have it. Please screen. It's particularly frequent in patients with coronary disease and aortic stenosis. At the moment, you can inhibit it by 15 to 25% with PCSK9 targeted therapy like inclisiran, like the monoclonal antibodies. It certainly works with apheresis. You get about a 60% reduction. But the bottom line is we have medications coming that will reduce it even further. And I think one of the key things is in primary prevention, and particularly family-linked primary prevention, please measure it. If someone in your family had early cardiovascular disease, there is a good likelihood that that was due to lipoprotein A. If it's raised in the index patient, it may well be raised in the family as well. So I'm going to stop sharing at this point, Dr. Naji. Happy to answer any questions.